Second time today. Sheesh. Leveraging technology to stay connected. So I have this little note taker here off to the side. It says Nicholas's AI note taker. And what this is, it's a artificial intelligence transcription of my voice, or actually anybody's voice during the session. And it will summarize the entire contents of the conversation into bullet points for you. So for free, I get a copy of the video, but also a high level transcription of everything we talked about. For a presentation, it's not super valuable because I have the PowerPoint, but for meetings, super high level output. So for those of you who haven't used ChatGPT or AI, it will be part of your life at some point soon. I promise. It's for those of you who know, you know. It's not the kind of technology that you can ignore. It's literally a game changer. I remember telling this to Kate, I don't know, 3-4 months ago, and now Kate's an avid ChatGPT user. And would you say it made your life more efficient, Kate?
It definitely did. It took a lot of, I hate spelling, and it really helps me with that and much more. It's very helpful.
Well, while we're waiting, I'll show everybody what ChatGPT is. Kate, can you see my entire screen?
Hold on, I was taking attendance.
I can.
Taylor, you can see it? All right. Let me bring it over here. All right. So here's ChatGPT. It's a website. It's an app. This is all of the information that I sought to put this presentation together. And the reason why it's helpful is there's specific things I want to address in the PowerPoint. And let's just say, for examples, I wanted to find a study comparing the fluoride compounds and their effectiveness, not effectiveness, but effectiveness. I get a really high level, filtered and distilled summary of all of the information that's out there on the internet versus having to go try to find it, only to find an article, maybe out of dental hygiene, dimensions of dental hygiene, or the ADA, or some other publication that's likely to have information about this, and then just realize that it was an article about fluoride, but it didn't really address what I wanted to. So then I have to go to the next one. And half an hour later, in a rabbit hole of not finding the information that I want. So you just type in exactly what you want, and the answer always comes out, and it gives you a conclusion. It goes on. I asked it, here's a list of 10 popular toothpastes along with their active fluoride components. We're going to go over this chart momentarily. But I wanted to see, of the 10 most popular toothpastes, which ones have different active ingredients, what was the concentration. It gave me it in percentages, but half of my preparation of this presentation had to do with parts per million. So then I said, please convert and add a column for parts per million. So you can see that in about 1 minute, I was able to obtain what I would consider the best chart to portray the information I wanted to get across, and also for me to learn. So whenever you guys see in the presentation a darker background, it's literally just a screenshot of ChatGPT. So that's it. Let's just ask something. So when I see a blue bird in Maine, what is the likely species? I don't know if you're excited about this as I am, but I find it pretty amazing. All right, so let's go ahead and get started. It looks like most everybody that has signed up is here. Kate or Taylor, you guys want to give me a verbal thumbs up? You can see everything?
I can see everything.
Perfect. All right, so fluoride and friends. Um, where did the origination of this topic come from? I'm always amazed when I'm out in public and somebody will ask me the question, which toothpaste is the best for me? And my answer, and I think many of our answers would be something to the effect of, as long as it has fluoride in it, it's good. And I think as a general rule of thumb, that's probably good advice. But I often say to myself, I truly don't understand what's in a tube of toothpaste. I'm not necessarily going to dive into that, but I think we need to understand fluoride specifically, its constituents in over-the-counter toothpaste and other modalities of fluoride delivery in the dental practice. So there was a question that came up in one of the practices recently where I was just astounded I didn't have the answer for the patient. So I wrote down that this was a topic I wanted to discuss during one of our sessions. Sodium fluoride, a little chemical reaction here. This is the basis of remineralization, or it's the start of the remineralization process in teeth. So I put these two photos here basically to say that this compound, in addition to other compounds, has a very large, significant contributing factor to dental health. Nothing surprising. I think we all know. 1CEU is provided by New England Center for Advanced Dental Education for you at no charge. That's my oath to you guys for those who are interested in bettering themselves. I love that you guys are taking time out of your busy night to do this. It means a lot, shows your dedication to the profession. And I'll record the video for those who can't do it. And eventually I'll try to do this in a way where if you're not able to make the session, we'll have a quiz that you can answer after to still get the credits. Here's the caveat, and I'm going to make this session the final session where I don't hold this accountability guideline. We need to have cameras on. So next time you sign up for a session, only sign up if you can turn the camera on, which means you get the credit, or you can keep the camera off, but you won't get the credit. I'm not doing this to be dictatorial or anything along those lines. It's literally part of my accreditation with the Academy of General Dentistry that I have some way of attesting to the quality of the participation of the students or the participants in the course. So this will be the last session that we let this slide. All right, so what is fluoride? It's a naturally occurring mineral used in dentistry to prevent tooth decay, found in water, foods, and dental products. Very high level, but I think it's worth just saying when patients ask us what this is, we should have this pretty well scripted in our mind's eye to be able to communicate to the patients that yes, this is a naturally occurring product. This is not a chemical that's produced by the evil dental American Dental Association and they get profits off of selling fluoride. It's meant to reduce tooth decay. So what's its mechanism of action? Well, the first two have to do with remineralization, and we'll take a look at that mechanism of action shortly. And the last is it has some effect on actually decreasing the bacterial activity of the bacteria in the mouth, which makes the bacteria less likely to metabolize glucose into acid, which is the mechanism of action for caries. So here we have a pretty high level diagram. I always try to find the best diagram that gets the point that I'm trying to make across. In a nutshell, hydroxyapatite is a mineral. I'd say it's a mineral. It's a mineral-based form of collagen. As you can see, there's phosphate groups in here. I say collagen. There's a word I'm looking for here. The point being that hydroxyapatite is what constitutes tooth enamel. And as we can see, there's hydroxyl groups, oxygen and hydrogen. When they dissolve based on a negative mineral balance or lower pH, going all the way back to Henderson-Hasselbalch's equation, the minerals can live in the saliva or the biofilm that surround the teeth. That equilibrium happens throughout our lives, and when there's an imbalance, we run the risk of demineralization, which over a long period of time can form caries. Obviously, we all know this, but I think it's worth revisiting. The relevant point here is when we add fluoride, and the F minus here is a fluoride ion. You'll see F minus and F2. We can think of those really as fluoride for the sake of tonight's argument. But the fluoride gets reincorporated into fluoroapatite. So this is a similar compound in our teeth when we're exposed to fluoride that's actually stronger and less likely to demineralize than hydroxyapatite. So when we think about fluoride addition in the mouths of our patients, it's more than preventing cavities, it's strengthening teeth. I'm not saying that we can chew glass marbles, but I think it helps for us to understand that this is more than just caries prevention. It's tooth strengthening, which has an effect on caries, thereby preventing the disease that ravages our patients. We also have the bacteriostatic mechanism of action, meaning when we have fluoride exposure in our oral cavity, there's an effect on this fancy thing. Anybody want to take a stab at what this is? This is the Krebs cycle. Essentially, this is where glucose is metabolized in our body, in the cells of bacteria. Essentially, the fluoride puts a wrench in the wheels of this by affecting this one compound called enolase. Mechanism of toxicity, related, unrelated. I just want to put this here. Yes, fluoride is toxic at certain levels. There's a very specific and known process that affects human cells. As we can see here, there is an effect. We'll talk more about toxicity in due time. So systemic versus topical fluoride. I think it's important that we, in our mind's eye, segregate out systemic versus topical fluoride, almost to the point we think of them as two different chemicals. Even though both of these routes of administration are delivering the same fluoride, I think it helps that we think of them in separate modalities because they have very different purposes for different people. So let's start with systemic, ingested. So we can take this in the form of tablets. We give tablets to kids who are on well water. Simple ingestion of water, community-based water supplies that have fluoride addition into it might be a way that somebody gets exposure to fluoride either intentionally or unintentionally. And then there's the topical approach, and that's where we're going to spend most of our time as clinicians, both hygienists and dentists, educating our patients about this separate and distinct route of administration for fluoride, either in the form of a toothpaste that they use at home, prescription toothpaste, varnishes, fluoride trays, so on and so forth. So again, bringing this concept front and center, think of these two different routes of administration as two different treatment modalities using the same chemical. Very important. And why is that? Well, there's different pros and cons and different risks and benefits associated with the different routes of administration, even though it's still fluoride. So if we look at the upside to the systemic delivery, I put time release exposure here. By that, I mean, if you're drinking public water each and every day, you have a pretty consistent time release exposure to fluoride. The downside is it's difficult to quantify. As we're going to look, we're going to learn how to quantify how much fluoride is in our public water supply based on looking at the CDC website that brings us to our state and local levels to find out exactly what we're ingesting or what our patients are ingesting with the public water supply. Well, because it's systemic and it goes directly into the system, it has the highest risk of toxicity. And I put this with a little bit of relevance. Relevance being, sure, if you ate 5 tubes of toothpaste in the topical column, you could call that a higher risk of toxicity. But I'm talking more about just general use. There's a higher risk of toxicity in the systemic route because it's harder to quantify how much fluoride we're getting from external sources, the primary one being community water supplies. Topical, one of the pros, easy application, whether it's a fluoride tray, fluoride varnish, or in their toothpaste, the dosing is easier to calculate in great part because we're giving the patient the dose. No different than when we write a prescription, we're calculating the exact dose that the patient's going to get, which gives us a better ability to balance the benefits with the potential risks. And then lastly, because of the feasibility in dosing, we have a lower risk of toxicity. But then I put here, although the risk of toxicity can be low with a topical approach, it can be high if inadvertently ingested in high amounts. So you can imagine a 2-year-old grabbing a hold of dad's Prevident, 5,000 parts per million, and ingesting all of that. Obviously, that's a risk. But that's not a risk of the product. That's just poor parenting, I guess. As I'm wondering where I put my Prevident. Yes, I use Prevident. All right, so community water fluoridation. Let's take a little bit of a detour and talk about this because I think it's such a huge part of how we deliver care to our patients, but it's very misunderstood, but underappreciated. So community water fluoridation is recognized as one of the top public health achievements, not only at the US level, but from the World Health Organization. As a general rule of thumb, it reduces caries by 25%. Some populations, some ages, different cohorts benefited varying degrees, but we can think of this as a fairly decent reduction in caries. It's important here to recognize that that's not a 100% reduction. That's a small reduction. So although this is important, proper oral hygiene, a good hygiene visit where we're educating our patients to the things that they need to customize their care helps with the other 75%. And at the end of the day, community water fluoridation is endorsed by the CDC, the ADA, and the WHO. This is all potentially changing thanks to a variety of different 2025 political changes. We'll leave it at that. But we're going to explore that at the end of the presentation. Actually, no, I moved them up. All right, so let's take a look at current legislation over the past 10 years in the United States. So I just typed in a chat GPT, please provide me the most relevant legislative updates on public water supply fluoridation in the past 10 years. That's what I get. It's super high level stuff. And it gives the reference too, so you can actually go to the source. There's actually 3 references here that's all aggregated into this one area. So they updated the fluoride concentration recommendation, actually lowered it. It used to be 0.8 to 1.2 was the kind of the general range that science had recommended communities attain for their concentration of fluoride in their public water. But more recent studies have shown 0.7 is kind of the sweet spot. So it's actually been lowered, and that's a good balance between positive benefit and lowest risk. Now, keep in mind the risk that they associated with this analysis had to do with fluorosis and fluorosis only. That might be a little bit scary because those of us out there who still think, and I'm phrasing this in the word we, in great part because I still think there's a possibility that fluoride can contribute to cognitive deterioration in children and adults. I'm not saying I believe it. I'm saying that I believe that there's a possibility. That possibility isn't built into the public water supplies range here. So that 0.7 number is simply based upon fluorosis risk. If fluorosis wasn't a thing and Dr. Google didn't believe that, when I refer to Dr. Google, I'm talking about the patients that come in that know more than we do because they read the internet. If Dr. Google didn't believe in this public health scare of autism and other cognitive behavioral deteriorations due to fluoride. So keep that in mind. 0.7 simply based on a balance of benefit and risk of fluorosis only. All right, fast forward to 2020, the U.S. Department of Health and Human Services set a goal to increase the proportion of people receiving water with the recommended fluoride level to 77%. Not sure where that number came from. By 2030, building upon 75 years of demonstrated safety and effectiveness. In science, there's several factors that we have to consider. One is proving causality or cause and effect is a lot harder than we think. And what do I mean by that? Well, this comment here, building upon 75 years of demonstrated safety and effectiveness, on the surface sounds pretty convincing. Yeah, we've been using this for 75 years and we haven't necessarily noticed a cause and effect of any sort of long-term health detriment. That's not science. That's just an assumption based upon a reflection of somebody's analysis of the history. double-blind, placebo-controlled studies done over a long period of time, and this kind of process is actually rather expensive and hard to do. All of this to say, I'm super conservative, but also an advocate for fluoride. You're going to hear me talk on both sides of the fence as we go through this, evidenced by, yeah, 75 years, we haven't really had a whole lot of effect. We've had a massive, massive decrease in caries that's been proven to be connected to public health or public water supply fluoridation. But we haven't really studied if there's any sort of negative effect. The jury's still out there. Needless to say, my kids get fluoride. They just don't swallow it. And we're going to get to that very shortly. All right, fast forward to 2024. A federal judge ordered the EPA to address potential risks associated with fluoride in drinking water, particularly concerning children's intellectual development. The ruling highlighted that fluoride levels might pose an unreasonable risk, prompting the EPA to consider regulatory actions. I don't really have much to say here other than this is the beginning of this conversation resurfacing. What's the guy's name? Kennedy there, Robert Kennedy. You know, he is an advocate that we get rid of fluoride. I think he's an anti-vaccine guy and a politician, and he's been known to really want to advocate for removal of fluoride in the public water supply. I don't know. I think we should be aware of this stuff, and I will keep everybody up to date as this unfolds. But this isn't the era that we were taught in school, where fluoride was safe. Don't worry about it. Anybody who tells you otherwise, dismiss them as patients. You know, that's what I was taught. And for the first 5 years of my practice, I used to fight with patients about this stuff all the time because I wanted to prove to them I was right. We'll talk about patient communication at the end of the presentation. Fast forward to last month, February 2025, Utah became the first state to ban addition of fluoride in public drinking water. So you can see this is happening right now. And I honestly didn't know that until I put this presentation together. I was like, goodness gracious, the things that happen in our profession that directly affect not only our career, but also our ability to treat patients is changing rapidly. And it's a very, very important thing for us to stay up to date. So if you don't have a journal that you read, either Dementia Dental Hygiene is a good one, the Journal of Dental Hygiene, or the Journal of the American Dental Association, where you're likely to see this stuff rise to the surface, I would encourage you to do so. I'll do my part in trying to keep this relevant and connected to our organization, but we're going to take it on ourselves to make sure we're staying up to date.
Didn't Damascotta get rid of fluoride in the water like within the last 10 years? Was it Damascotta?
Yeah, I don't know. I know there's several, and actually this slide right here brings up not Damascotta, but it says discussions about water fluoridation continue at local and state levels, for instance, and then they talk about a city that's having this conversation. I do have the ability, and I'm going to show you guys shortly, how we can look at each individual city and town to see if the public water supply is fluoridated or not. And that's where we're going to head here. So we talked a little bit about, you know, what the range is where we start to see the risk of fluorosis at 2 milligrams per liter, which is 130% more than the 0.7, 115%, sorry, doing math in my head, more than the 0.7 recommendation that we have. So really, we're pretty far away, at least from a public water supply perspective, from having a mild risk of fluorosis, and then 4 would be a severe risk of fluorosis. The problem with this is this recommendation is making a lot of assumptions. How much water is the person drinking per day? Are they using other fluoride supplements? Are they using high fluoride toothpaste? So this whole conversation is very much just a framework for us to begin to customize care for patients. But at the end of the day, I'm hoping that everybody that's watching this will have a better understanding on how to customize fluoride recommendations for patients based upon their age, where they live, whether they're on a public water supply or not, their caries risk, their perio risk, so on and so forth. Concerns for potential fluoride toxicity. I think we've gone over all this, so I'm gonna move forward. All right, so let's take a look here. So I'll send a copy of this PowerPoint out, and on one of the slides, there's a link that'll bring you to the CDC's website where you can select the state. What's interesting is there's several states that don't actually give the CDC data on their public water supply filtration of fluoride. So you click on that, and then what would Damascotta be? Washington? No, Penobscot, right? Penobscot or Kennebec.
I'm not sure. Maybe Kennebec because it's kind of like after Bath Brunswick.
Yeah, it's kind of hard to tell because they don't necessarily name the town with this.
Dr. Roy, I just went on chat and it says Kennebunkport, Wells, Ogunquit, Arundel, and parts of Biddeford in 2016 decided the residents voted to cease water fluoride.
Wow.
And Southwest Harbor, Jackman, Moose River, Mount Desert Water District, Lincoln, Norridgewock. So
It's happening.
just to add the 2 cents.
Yeah. So it looks like there are local municipalities that are having an active conversation about this. And it's interesting how I don't know any dentists who partake in these conversations. So this is where you can go to find that information. They don't actually have the fluoride dose here. I think this just says yes or no, and I would assume that they follow the 0.7 recommendation. So if you see yes here, you can assume 0.7 milligrams per liter. Milligrams per liter.
I know that Lewiston lowered their fluoride level. I forget when this was in my career, because they were saying that people were getting fluoride from like fountain sodas and
Right.
just so many other places. So I feel like they went down to like 2 parts per million, but I'm pulling that out of my butt. I just feel like they did decrease it at one point.
Yeah.
When I was living in Lewiston.
Mm-hmm. I seem to
and Auburn was trying to get rid of it. They were trying to get it on the ballot a few years back too, but I don't think they ever did.
You recall what that effect is, where there's other exposures, relative exposure?
What was that?
The halo effect of fluoride.
Oh, okay.
If we ever hear that, what it's referring to is the public water supply is not the only source of fluoride in people's exposure in today's day and age. And I think there's even some water that you buy at the supermarket that has fluoride in it, because it's coming from public water supplies. So I tried to go to the main website and try to find a way to locate this, and I wasn't really able to. It looks like it's somewhere in here, but I typed in fluoride and search drinking water. Anybody ever find how absolutely useless these search bars are on websites? I never find what I want. I type in fluoride, it's like, oh, we don't have anything. Well, I'm sure it's in here somewhere. Needless to say, you can find the information for your patients here. And I think it'd be good for each of the practices to get maybe a heat map of each of these districts. And I think that exists. I feel like we had one once in the practice, maybe 10, 15 years ago. Let's go back to this. Here. All right, so what's the moral of the story? Topical fluoride is the preferred mode of action in the reduction of caries via fluoride delivery. Fluoride varnish, fluoride trays, 5,000 ppm fluoride for adults, and topical delivery fluoride for children, especially in towns without public water fluoridation. We're going to update that slide. What's important here is fluoride varnish. I'm going to go over this in detail. Is safe for kids and infants. So the moment they get a tooth in their mouth, if they're at high risk for caries, there would be no reason not to. And we'll look at why that is. Safety and efficacy. Going over this, fluorosis. A lot of this we've already discussed. Fluoride and autism. So there's no credible scientific evidence to support this link. There have been some recent studies reviewed by the CDC and the NIH, but they found no causation. With that said, this was a rather difficult connection to prove scientifically. And typically when it's difficult to prove, the consensus summary statement is there is no connection. So whenever you're reading something, if it says the connection has been proven to be absent, that's a very different statement than there is no evidence to support the link. Whenever you see this, the latter statement, what they're saying is it's maybe hard to study, or the cost of the study is prohibitive, and it's just not, that connection hasn't been made yet. So here we have, this is important, so we're going to bring it up. In 2019, a review entitled "The Chronic Fluoride Exposure and the Risk of Autism Spectrum Disorder" examined the role of fluoride in ASD idiopathology. The authors assessed how fluoride might contribute to metabolic and mitochondrial dysfunction, oxidative stress, and other factors. They also discussed the potential for synergistic effects of fluoride with aluminum ions. However, it's important to note that this review primarily highlights theoretical mechanisms and associations rather than establishing a direct causal relationship between fluoride and autism. Additionally, a 2024 study investigated prenatal fluoride exposure and its association with childhood neurobehavioral problems. The researchers found that higher maternal urinary fluoride levels during pregnancy were linked, not proven causal, to increased neurobehavioral issues in children at the age of 3. While this study does not specify and address autism, it adds to the body of research examining fluoride's potential impact on child neurodevelopment. So what does this mean? Again, where there's smoke, there's fire sometimes, and this is smoke. So I think we have to be very conscientious as providers who really care for our patients that, you know, we're being very smart about how we recommend things. We don't fight patients on either side of the fence. We're very neutral in our understanding that science is constantly evolving. And our goal is to pay attention to the science as it evolves and make the best recommendations for the patient situation based on the science. And if the patient doesn't want to take those recommendations, we record it in the patient record. You know, we don't have to get emotional about this. If we're strongly convicted that there is not a link here based upon your analysis, that's okay if somebody does think there's a connection. Your job isn't to convince them. I promise you, these people are not convincible. When I say these people, I'm talking about the people who are convicted about their belief system. Just take a look at her political debates on Facebook. There's no convincing people when they believe something, you know, and this is when they're emotionally in belief of something. And I think this is one of those things. So our job isn't to convince, it's to support and educate and be compassionate. So what is our stance? So I just came up with this sentence or this statement. At SRD and our affiliate practices, we believe that science is always upgrading our understanding about standard recommendations. At this time, there's no quality evidence to support a link between recommended fluoride exposure, and I put recommended in quotations. If people are taking the recommended doses and they're conscientious of the exposure to either themselves or their children, then they're in a category of quote unquote safe. And we're talking about these people linked to autism and other cognitive issues. With that said, we aim to use fluoride in a very judicious manner, which includes rationale for utilization, proper risk assessment, dosing considerations, and environmental analyses. So this is my belief. I believe fluoride is absolutely relevant to the conversation. I don't believe it's a binary decision, which is yes or no. I think fluoride has its place, but it needs to be decided upon with the parents, with the patients, but using this rationale for utilization, proper risk assessment, dosing, environmental analysis to come up with the best decision and the best recommendation. So if anybody ever asks you, does Sauk River Dentistry and its affiliate practices recommend fluoride? The answer is when the time is right. Not yes, not no. Anybody want to take a stab at this? This is absolutely something we can change based upon changes in the landscape of the profession.
I think it would be a smart idea to have like some sort of a info sheet. Like if someone doesn't want fluoride, that's fine, but maybe like just a conversation about nutrition or airway, just to like make sure that you're brushing your children's teeth and not leaving plaque behind and limiting snacking and like that sort of stuff as to the
Right.
risks for decay, so that they at least know like that's fine, you can refuse it, but then you should be doing extra on these fronts to help prevent decay.
Well,
And
it's
like that
about,
would be us doing our due diligence, that we gave them like a little tips and
yeah,
tricks thing, so they can't be like, well, my kid has all kinds of cavities, I didn't really know the truth about it. You know what I mean? Like it just helps to balance out
yeah, love
the
it.
negatives.
We could call it the non-fluoride carries risk mitigation strategy. Obviously, something much more.
Well, because
Much more.
honestly, if we're being honest, a cavity is not a fluoride deficiency in the tooth. So
Sure.
it's possible to have healthy teeth without fluoride, but people have to be like putting in the effort. If you don't want to do the extra step to remineralize, then like what are you going to do to not get a cavity on the other side of that?
Where did you come up with that? No such thing as a fluoride deficiency in the tooth. That's really
Well,
cool.
I
Is
heard
it?
that once and I thought that was really cool, because it's not
It
like, because
highlights.
everyone's freaking out about taking water out of the fluoride system and all, I mean fluoride out of the water system, but I'm like, you can get fluoride in other ways, and you also can prevent cavities in other ways. It's not like everyone's gonna all of a sudden be rotting out because they take fluoride out of the water. Like
Right.
there's other ways to mitigate it.
Yep.
So anyway, that's just what I've been telling
Beautiful.
people.
I wrote it down because it has high impact for me. I'm sure it resonated with others. So thank you, Taylor, for sharing that. Does fluoride lower decay rates? Everybody remembers from school the Grand Rapids fluoridation study, where I guess he worked for the U.S. Public Health Service, Dr. Dean. Essentially compared two cities, one that was fluoridated and the other that wasn't, and there was a 42% difference in caries risk in children. Actually, after 11 years, showed a 60 to 65% reduction in caries. I was looking at a different study, the 42%. The point is, this was a study that started the conversation about putting fluoride in the public water supply. I don't think we need to look at this, but I think it's good to know that the body of evidence about fluoride lowering decay rates is absolutely 1000% rock solid based upon analyses like this. So anytime you see the word Cochrane is a Cochrane review is a highly respected systematic and evidence-based review of research in healthcare and health policy. So essentially it's not a study, it's a review of many studies, and sometimes it's a review of meta-analyses, which are a review of studies. The point is that when a Cochrane review is done, it's looking at a very, very large data set. Not everything can be studied under this analysis, but I suffice it to say, there's no question fluoride does lower decay rates. It's just a question of the risk and whether that's relevant or not. Like we talked about earlier, there's a 25% reduction in caries across the board due to public water supply fluoridation. But is that enough? And like Taylor alluded to, there's other ways of doing it, and we're going to talk about that. But let's have a quick conversation about fluoride specifically. Do we increase the exposure concentration? If so, do we do a systemic or a topical approach? Do we increase the exposure time or duration, such as using fluoride trays or varnishes and understanding what those time durations are? Do we consider upgraded plaque removal as primary modality for risk reduction? There we go, Taylor. So there are other ways to reduce the risk, but it's like a Venn diagram. Fluoride is one circle that overlaps with oral hygiene, that overlaps with diet. It's that intersection that caries occurs. We really should have a strong conversation with each of those entities separately. And then lastly, do we consider additional therapeutic modalities? such as anti-paste and other forms of milk rinses and water picks and all of these adjunct tools that can help us lower decay in patients' mouths. All right, so let's take a deeper dive into the options available to us as clinicians in dentistry. So we have fluoride varnishes, fluoride trays, stannous fluoride, fluoride in MI paste. These old trays here, I forget what that was called, acidulated phosphorus fluoride, APF, the foam that used to go into these trays, which was acidic, acidulated, acidulated APF. So you guys know. Many ways of delivering this, but let's start with over-the-counter toothpaste. So a question that often comes up, which one is best? If you have a preference, I would encourage you to put that recommendation through the filter that we're going to talk about. In great part because Crest, Colgate, there's another company, I don't know if it's Pfizer, that owns another big toothpaste company, are very good at brainwashing us. So I would encourage you not to believe in a toothpaste is best until you understand why. Honestly, at the end of the day, if it has fluoride, it's doing the trick. But there are differences, and for different patients, there are different reasons to recommend different toothpaste, over-the-counter toothpaste. So what is the concentration? 1,000 to 1,500 parts per million of fluoride, at least in the form of sodium fluoride and sodium monofluorophosphate, is about 1/5 to 1/4 the amount of fluoride that we see in Prevident or Clinpro, which is the prescription fluoride. How did we arrive at this concentration? I had often wondered this. Why do we use this certain percentage of fluoride in toothpaste over the counter? Well, the early studies basically showed the maximum benefit with the minimum risk of dental fluorosis. So that it's that balance again that was used to come up with the public water supply was also the same rationale for concentration recommendations for toothpaste. One of the things I have a beef with is we use different concentrations when we're recommending this. So as clinicians, we tend to think in parts per million because we have Clinpro that's based in 5,000 parts per million. But then you look at a tube of toothpaste and it has it based on a percentage. So I asked ChatGPT to provide me a conversion chart to equate those. So essentially 0.25% is about 1,100 parts per million. Is this important? Well, if you're looking at a tube of toothpaste and your patient's asking you, is this a good tube of toothpaste? You have no idea what that 0.24% means, and you have no idea whether sodium fluoride or sodium monofluorophosphate is better. Hopefully we're going to unpack that right now. Here's a chart. I asked the famous ChatGPT to provide a conversion chart from 1,000 parts per million to percentages for various fluoride concentrations. And as we can see here, there's different percentages. So when you look at different tubes of toothpaste, you're going to see these different percentages, which translate over here. Well, if you have a patient with high caries risk, but they can't afford to buy the prescription for whatever reason, what's our recommendation? Well, we need to know what the higher concentration over-the-counter fluoride constituents are. Well, if I saw 0.76% fluoride, I'm ignoring the long word here, I would say, oh, this is better than 0.243%. The problem is percent sodium fluoride does not equate to percent sodium monofluorophosphate, MFP. These are about the same in their effectiveness, at least based on some of the studies I read. So this is important. This is the most important consumer aspect of our profession. And I'm confused just describing it to you guys, as you can tell. But what I'm trying to do is I'm trying to advocate for all of us to upgrade our understanding at this. I'll share these PowerPoint slides and you guys can read them and do whatever you may with the information. Maybe bring your questions to ChatGPT and say, please provide me with the two best toothpastes that are sodium fluoride, that are also the cheapest. It'll give you that answer. So I asked ChatGPT, give me the top 10. This For those of you who were on the call at the beginning of the session, I showed you how I came up with this using ChatGPT. As we can see here, there's three major forms of active fluoride. There's sodium fluoride, stannous fluoride, which we haven't talked about yet, but we will, and then the MFP version. The concentrations over here in parts per million, the concentrations in as a percentage of total volume. Anybody have any questions about this? I'm sure everybody's looking at their favorite company and saying, oh, where do they land in the hierarchy of things? Let's take a look at the different forms of fluoride so that we can gain some understanding why the companies use different forms. Starting with stannous fluoride. So stannous fluoride, at least in my career, has not been super relevant. It pops its head up every once in a while. When I was in college, I had the beautiful opportunity to work for a prosthodontist while I was in college, and I got the shadow downstairs at a peri office. And I did that for 2.5 years. So it was a really good indoctrination into the profession before I headed off to dental school. And the periodontist downstairs used to recommend stannous fluoride a lot. And I remember getting to dental school, not hearing much about this. It stains teeth. That's all I remember is ST for stannous is ST for staining. I never really thought much of it. Well, it's come a long way. And as it says right here, modern formulations like those in Crest Pro Health now use stabilizers to decrease its chemical instability. I kind of skipped over this. So the stability issues is the first problem with stannous fluoride, which they've fixed. The second one is tooth staining, which again has been fixed. And I can't say, is it fixed 100%? Is it 75% less staining than it used to be? But it seems to be, I mean, Crest Pro Health, I feel like everybody uses that. And I don't recall anybody ever saying that they're having stained teeth. Although I wouldn't be surprised if they put it in there only to sell their whitening kits. Beautiful marketing strategy to increase profits for a public company. The point being that I don't think stannous fluoride is actually a very good form of fluoride, which we'll look at momentarily. And the reasons why we didn't use it historically seem to have been solved. Continue to go here. The taste and the mouthfeel tends to be a little bit of an issue. I'm not sure if that's relevant. I mean, I've used Crest Pro Health for years. I use whatever toothpaste is free. So when I go to Yankee, I stock up. So I have no allegiance towards any toothpaste. But point being, I definitely have used Crest Pro Health, and I don't remember it being non-palatable by any stretch. It is more complex to manufacture, which does increase its cost. So stannous fluoride combinations tend to be more expensive, but for the right patient, might be worth it. But this is an important part. I think this is why the periodontist was so high on stannous fluoride. It has a much more pronounced bactericidal and bacteriostatic effect, specifically for P. gingivalis and Bacterium nucleatum, which are two very specific bugs that cause gum disease. So it would stand to reason that if we had a patient that maybe had low caries risk but had gum disease, that we consider using stannous fluoride. Some of you might already do this. Those of you who haven't, I invite you to upgrade your understanding of stannous fluoride and kind of weave that into your customization process for your patients. Anybody want to talk about stannous fluoride? Any experience with it? Experience from the previous generation of stannous fluoride that was maybe more detrimental and had more side effects to today?
I'm still traumatized from gel cam. So much stain. It was awful. Has anybody else had gel cam
Yeah.
stain?
I remember that product. Go ahead and share your experience as a patient or as a provider.
As a provider, the first doctor I worked for, or second doctor, sorry, they had gel cam toothpaste and rinse, I believe. And they had a lot of patients on it, and everyone came back like their tooth was dipped in brown. It was so gross. Like it
Wow.
polished off, but it took a lot of elbow grease.
Elbow grease, yeah. Anybody have experience with the more current generations of stainless fluoride. Well, let's continue to have this conversation. Again, one of the big reasons why I put these presentations together is because I learned a ton tonight. So I'm going to upgrade my understanding here, and I'll share any high-level stuff with the group. But I think it has its place for the right patients. So if you're not familiar with it, you're not using it, at least a certain percentage of the time, there's probably a place for your patients. What about baking soda and peroxide? So the crest cavity and tartar protection. Interestingly enough, this is the cheapest toothpaste out there at 29 cents per ounce. In great part because it's just baking soda, sodium bicarbonate, pretty cheap. But this is, it's a well-known fact that before fluoride was a thing, people brush with baking soda. Yes, there is a mild abrasive action, which can help to some degree, but some might say that it actually can increase abfractions and resurface defects. I think where this comes in is our tartar builders, because of the pH buffering. Maybe we consider either recommending this toothpaste for them, as long as there's fluoride in it, or having them rinse with baking soda and water, which is what I've recommended that for years. My 5 caries risk protocol, 8 ounces of water with a teaspoon of baking soda, rinse for 30 seconds. For patients, especially after their meals, who don't have a lot of saliva, that's a magic trick that they can use. What happens after they eat? So if somebody doesn't have a lot of saliva and they eat a meal that is somewhat acidic, if nobody has to reply, but let's give you guys a second to think about it. What's the problem? The buffering capacity of saliva isn't there because there's no saliva. So how do we replace buffering activity after meals in patients that don't have saliva? Baking soda and water. So for our patients who come in that are 80 years old, severe dry mouth, root surface caries, one of the easiest things they can do and the cheapest things they can do is, for instance, baking soda after the meals or after any acidic exposure, whether it's soda or meals. Cost analysis. Again, I'll send you the PowerPoint. You can do with this as you may. Point is, the Colgate cavity protection seems to be the cheapest by a mile. It's just basic sodium fluoride. That's all it is. Toothpaste. And things get more expensive as we start to talk about Sensodyne, in great part because the potassium nitrate that's in there that decreases sensitivity can be rather expensive. The Crespro Heallth is stainless fluoride, so it's more expensive. So we have to be conscientious of this for our patients and let them know, hey, there's a reason why I'm recommending this. Here's the reason. You're going to notice it's going to be more expensive than some alternatives. But if you build the value in the eyes of the patients, the cost should be less of an issue. So there's a summary of over-the-counter toothpaste. I'm going to move forward here. Let's go to 5,000 ppm fluoride dentifrice. A few studies here if you want to take a look at the value of this concentration in the reduction of high caries risk in adult patients. Adult patients, we don't prescribe this for kids. There we go. So different ways of using the dentifrice. Many of you who have done exams or worked on patients that I've done exams for you have probably heard me say something to the effect of brush with your regular toothpaste, use the toothpaste as your dentifrice, and then take a pea-sized amount of Prevident and spread it on your teeth, or use fluoride trays. The reason for that is the 5,000 ppm toothpaste is not, there's not a whole lot of abrasives in it, which abrasives do have their place in reduction of plaque. So I recommend using, and I can appreciate there's all kinds of ways of spinning this, but this is just my rationale, my current rationale, subject to change. Regular toothpaste followed by high fluoride toothpaste with no rinsing. Simple formula. Can't say if it works because I haven't studied it. Pretty hard thing to study, but the science that supports that recommendation is rather high. For patients with significant risk, why not make them fluoride trays? And I would say part of this presentation is a advocation for everybody to upgrade their recommendation for fluoride for the patients that need it. Fluoride varnishes and fluoride trays being the primary focus area. So if you're not part of recommending fluoride trays, hopefully this conversation gets you excited enough to start thinking about how you can upgrade the dental health of your patients through modalities like this. One question I often had, and I think I answered it here. How long should patients wear fluoride trays? I was taught several different things from several different people, and I think all of them had good intentions on their recommendation, all the way from 5 minutes to 8 hours during sleep. Science pretty clear, 20 to 30 minutes seems to be the sweet spot at which there's a law of diminishing return after 25, 30 minutes where the effect isn't that great. So what I would say is 20 to 30 minutes, a number of times a day. I put 2 times a day here, depending upon their risk analysis and their tolerance for doing this, and their ability to afford the fluoride that goes in here and the cost of the trays. But at least we have a scientifically sound recommendation of the duration of this concentration of fluoride in customized trays for patients, 20 to 30 minutes. Fluoride varnish. ADA recommends the use of fluoride varnish for any individual, including children and infants at risk for developing caries. Not going to go over application, but the frequency is something that I had often wondered. Why don't we give fluoride varnish every time a patient comes in the chair? Again, with risk analysis being built into it. The current recommendation is 6 months for low caries risk. Does that mean somebody that doesn't have caries? Low caries risk is a relatively subjective term. But suffice it to say, if the patient has a DMFT score that is above 1, one could argue that they have a low caries risk, which means they should get fluoride every time they come to the office for their cleanings. All the way down every 3 months, which is 4 times a year for patients that are at high risk. This is interesting. So I think we have an opportunity here to really start building out a fluoride varnish program. I don't know what that's going to look like. I invite you guys to send me an email on some thoughts here. You know, at the end of the day, fluoride varnishes are a revenue generator in practices. I'm speaking from a global perspective as somebody who spends much time in the profession. It's not uncommon that I'll have a doctor ask me, how many fluoride varnishes do your hygienists average per day? Like, as many as our patients need. It's some sort of like righteous thing for clinicians to say, you know, I've brainwashed my hygiene team to give fluoride to everybody that's breathing. I don't believe in that, but I do believe in very strong science supporting very good conscientious decision making that leads to treatment recommendations that's not based on insurance plans. What am I trying to say here? I think we can all do a lot more fluoride, and it's not about the money. It's about the science. It's about reduction of caries risk in our patients. So we're going to start measuring this. Again, we're not measuring it for productivity purposes. We're measuring it because there's going to be a standard average that the group amongst the organization kind of gravitates to. There will be a bell curve on fluoride varnish recommendations across the board. If you're on the short end of the bell curve, that just means that you're prescribing less than the average person. If you feel that you're prescribing the proper amount, let's have a conversation about it. But the odds are, if you're on the left side of the bell curve, you probably have room to grow. And let's look at the science together and get you on the other side of it, at least at the top of the bell curve. If you're on the extreme end, either you understand the science or you know how to communicate with your patients at a much higher level, and we're going to ask you what that is so that we can all move the bell curve to the right. This is a concept that we're always going to talk about in the practice. Where do we live in the bell curve as providers? This is a great opportunity for us to really shine a light on that particular concept. So we talk about rosin, you know, the pine tree nut allergy. There is a fluoride varnish called Profacil that doesn't have any of the rosin. I don't think it has the stickability and the longevity that the others do, but for patients that have a bona fide allergy, it might be something to consider. The other three major ones, Fluoride Vanish, which is what we use, does have it, and I think everybody knows that. My son is. Hey, oh, hi guys. All right, I'm wrapping it up, and I'll put you guys to bed. Yay. All right, I'm going to send this. This was pretty much it. I'm going to end with this, the 3-month fluoride challenge. Excuse me, guys, for a second. Hey, can you guys go upstairs, please? I'm going to finish, and then I'll be right up. Beckett, I asked you guys. It's 7:31. I told them 7:30 I'd be done. They held me to it. All right, so to advocate for more fluoride in the practice, before I talk about this, Taylor made an excellent point. Fluoride is not the answer, but it is a strategy. And we have to be very conscientious of that fact as we educate our patients, but having this tool be a much more easily accessed tool is what I'm advocating for here. So what we'll do in 3 months, I quit July 1st, the first week of July, whatever the first Monday of July is, Kate will produce a report. All of the hygienists who have coded out for fluoride varnish will get one golden ticket. Essentially, you get one ticket to be drawn, and we'll draw randomly. 2 people will get $1,000 cash prize. The doctor who did the exam will also get $1,000 prize. Maximum of 1 prize per person. We want to spread the joy here. So once if you win the first one, you don't have the ability to get the second. This is going to take a lot of teamwork, and I would really advocate that you guys talk about your fluoride numbers. I feel so dirty saying that because I hate numbers in dentistry. I feel like that's just the wrong perspective, but I'm learning that if you're using numbers in a strategic way to have a positive impact on the patient's health and well-being and their quality of life, that's safe. I worked in a practice where it was all about the money, and the quality of the care had nothing to do with the conversation. And that left a stain in my professional brain for the rest of my career. And that's where this fear comes from. So on that note, just about an hour. Anybody have any thoughts, questions? Was this too basic? You learn at least one thing? All right, Mitch. Our Harvard's alive and well. Taylor's alive and well. Amy, all right. Thank you, guys. All right, have a good night. When your head hits the pillow tonight, ask yourself, how can fluoride impact your patients? But at the same time, understand the risk associated with its improper use. Stalker, such a bonehead. All right, guys, have a good night.